She was begun on antibiotics, initially ceftriaxone, and then she was escalated to meropenem. And then due to the anemia, she had a transfusion, and then she transferred to me for an assessment of what they thought was a infant leukemia. So here is her initial evaluation at the outlying hospital. Her white count was 52,000. Now, babies tend to run a little bit higher than older kids, but again, 52,000 is considered outside of the normal reference range. They did comment about the presence of predominantly blasts on her peripheral smear. She had a low hemoglobin of 6.8, which led to the transfusion. Her platelets were not that low at 113,000. Often in these lymphoproliferative conditions, we obtain markers. Uric acid is one, and the other one is the lactate dehydrogenase. The higher the number, the higher the disease burden. Our reference range is up to 400, so almost 1,300 is threefold. It's not quite elevated. Sometimes I've seen people into the 1,000 range, but she did not have any hyperuricemia, which is always good because we don't have to worry about the tumor lysis syndrome and the renal complications that do come with it. We always look for disease burden, so you want to make sure there's no mediastinal disease. So she had a chest x-ray, which came back fine. Even though by examination there was no hepatosplenomegaly, I always look at the abdomen because I'm also looking at nephromegaly. Sometimes these people struggle because they have leukemic infiltration, which makes the treatment a little bit more of a challenge. She had no evidence of any viral etiology, so people that are CMV positive, sometimes we have to worry about complications once they start to receive chemotherapy, but she was seronegative. And again, when we asked for a peripheral smear at our institution, she had 48% blasts. And then often we make a diagnosis on a peripheral blood if you have abundance of white cells, and especially if you have a lot of blasts. And so this one, she typed positive for the common form of childhood ALL that we call B cell in origin. The family was kind of leery about the diagnosis. They sought multiple opinions. They sat on this probably for about 1 week. And finally, they said, okay, we can proceed with the chemotherapy. So we proceeded with a bone marrow evaluation almost 10 days into this. She was quite stable the whole time when we did not initiate any therapy. So on her bone marrow evaluation, she had 84% blasts. By definition, once you exceed 25%, you do have leukemia. We do flow cytometry because you want to know, even though it's lymphoblastic, whether it's B or T, because we have a different treatment regimen for each immunotype. Most babies under 1 have B cell. Occasionally, you may see either a T cell or you may see a combination of myeloid/lymphoid presentation, but the majority have B cell, just like in this one. We do cytogenetics on the bone marrow, especially in the older kids, because we put a lot of emphasis on the number of the chromosomes. So if you are more than 46, say 50, 56, we call it hyperdiploid, and people do a lot better than if the chromosome number is, say, 44 or 45, which is called hypodiploid, which portends usually poor prognosis. So her cytogenetics were normal, which sometimes is misleading. So you may not see a translocation. Typically, the 411 is the most common translocation in infants with ALL. But we went ahead and did a FISH analysis. So fluorescent in situ hybridization can give you more accurate information. We always look at what we used to call MLL, the mixed lineage leukemia rearrangement. Now it's called the KMT2A, and she was positive in half of her nuclei. Most babies are usually positive for the KMT2A rearrangement in about almost 80%, which makes treating infants with ALL very difficult. The minority that is only 20% usually do extremely well with chemotherapy. So normally you don't want to see this rearrangement, but that's the story of infant ALL, that they do come with this kind of rearrangement, which I'll talk about in a minute. So then how do you go about treating an infant with ALL? The treatment is quite prolonged, and so you would need some sort of venous access. So we had a portacath in place to facilitate administering her chemotherapy. Induction, we normally, for regular childhood ALL, so now I'm talking about those who are not infants, we have two forms of induction. For those that we call the standard or the good risk, it's typically a 3-drug induction. So we spare them the exposure to the anthracyclines like the daunorubicin. Those who are the higher risk patients, so those who are over 10, or those who have an elevated of white count, say to over 50,000, we call it a 4-drug induction, where you would use 4 medications, including the addition of the daunorubicin. So if you look at her induction, this is a 5-drug induction. The vincristine, the daunorubicin, the prednisone, and the PEG asparaginase are the standard concoction that we use for regular childhood ALL. The addition of the ARSC has been shown to really help with the induction, because these blasts do have a little bit of a myeloid expression, myeloid antigen expression. So babies are known to harbor that sort of abnormality on their screening when you do the flow cytometry, and ARSC has been shown to help in AML. So it has been incorporated now in the frontline induction. So she was receiving what we call a standard infant ALL induction. There are different protocols. In Europe, they use a protocol called Interfont. And so for those of you who are more familiar with that region of the world, it is a multinational study. They had 2 versions. One opened up in 1999. The most recent one was in 2006. In the US, this was the latest treatment. It's called ALL 0631. And I think it has accrued about 110 patients by now. Infant ALL is very unusual. It only is about 2 to 4% of the entire ALL. So in the entire USA had about 55 patients per year. So this is not something that you're going to see on a daily basis. Induction is very tricky. So you need to be at a center that knows how to monitor for the complications. She had norovirus that gave her severe diarrhea. So we had to place her on TPN because her feeding was very compromised. And then halfway through her induction, she became febrile. Luckily, it was not very hypotensive. And we cultured her and started her on broad spectrum antibiotics. She had Klebsiella pneumonia, bacteremia that we've managed to conquer. And then the most important thing is you go through this whole ordeal. You want to really achieve what we call minimal residual disease status. So when do we do this? Typically, we call it EOI, or end of induction. So after you've had your chemo for about 4 to 5 weeks, you come back, you do the bone marrow, and then you see how much of disease reduction did you affect. And if you see a number that is less than 1 in 10,000, then we say this is a molecular remission. So this is very important. A lot of people who did not do well in the long run is because they could not achieve this initial lowering of the disease burden. So that has a very important prognostic implication. And then obviously with the whole intensity of her treatment, we had to rely on what we call supportive care measures. So in addition to transfusion, we were careful about fungal disease. And so we prophylaxed these babies with either micafungin or caspofungin. We gave her Septrin because we don't like to use pentamidine under the age of 1 for PJP prophylaxis. And then we monitor their IgG level and we give them replacement in order to help boost their passive immunity. And luckily, since October, we have not had any bacteremic episodes since that time, even though she continues on a very intense chemotherapy regimen. So I'll start by just talking a little bit about acute leukemia. So this is ALL and AML in infants. So where do we draw the line? And the protocols are very specific. It's less than 366 days. 20 years ago, I had a baby who was like 365 days. And then when we made the diagnosis, it was the day after, and the father could not understand that at the time of her presentation to the hospital, she was 365 because he did not want her to be on a very intense chemotherapy, but we're very strict about agents. So it has to be 366 days or less. As I said, it does have abnormal cytogenetic features that usually are concerning, which is the KMT2A rearrangement. What this protein or the fusion protein does, it is adds chemo resistance, and these babies have a high relapse rates. So it is sometimes easy to induce and get in remission, but the remission is usually short-lived, and a lot of people do relapse. And we know relapses early on are different from relapses later on. So if you relapse on therapy, your outcome is going to be very dismal. How they present, almost like the way she presented. She did have the fever, the pallor, the crying was because she was irritable. What she did not have is what we call a big extra medullary disease burden. So some infants can present with skin lesions. We call it leukemia cutis. Sometimes people classify it under what we call blueberry muffin syndrome. And I remember seeing a baby at 6 weeks of age who came with a white count of 1.3 million, and she had these very purple skin nodules in her skin. They can present with significant organomegaly, and often they come with a very high white count. Any white count over 100,000, we call it hyperleukocytosis. These babies, usually the younger they are, the higher the white count, and they can come with a 300,000 white count, which is not unusual. They also come with chloromas, which is a constellation of blasts, and usually it is located, say, in the eye. And then when you do the initial CSF, often the first CNS is positive. So it does require more intrathecal chemotherapy, and those who do not clear their CNS, we place sometimes Ommaya reservoir. So we keep administering intraventricular chemotherapy. The one difference is the incidence between ALL and AML is almost 1-to-1 ratio. So if you look at a general childhood leukemia over the age of 1, for every 1 AML, we see 4 ALL. So usually ALL is about 80-85%, AML is 15%. But once you're down to the age of 1 or less, the incidence becomes identical, so almost 50-50. And I just mentioned that these cells do have a myeloid antigen expression, and this is why we've been introducing the concept of cytarabine into their main treatment. Now, the ALL in infants acts also differently from the ALL in older children. So when we do the flow cytometry, most common childhood ALLs over the age of 1 have the expression of CD10 marker. Babies usually are CD10 negative, as was the case in this patient. They do have that myeloid antigen expression that I alluded to. And then when we look at prognostic features, the first thing is we look at the KMT2, whether it's in a germline or rearranged. So only 20% are in a germline and they do better. 80% it is rearranged and they're not going to do as well. And then we look at age in months. And so even though you're lumping all babies under the age of 1, we have those who are less than 90 days, and these do extremely poorly. Then you have those between 90 days and 6 months, and they are intermediate. And then those who are over 6 months usually do better than the younger ones. So luckily, she was 10 months of age. She did not have an extreme elevation of the white count. So for those that we call low risk, so those over 6 months, no extreme elevation of the white count, germline KMT2A, the cure rate is about 75%. Not a bad number for this extremely poor risk population. On the other hand, you have the high risk, which is under 6 months, extreme elevation of the white count, and the MLL rearrangement, and it is down to 20%. Our patient, we are treating her according to what we call intermediate risk because she did have the rearrangement, was not under the age of 6 months, did not have a very high white count. And in most studies, the cure rate is about 40 to 45%. There have been 3 big studies, and it's exactly between 41 and 44. There was only one study in Japan, limited by number, maybe 19, 20 patients. They quoted a 93% cure rate, but I think it study suffers from just the lack of having enough population because almost 500 patients between European and American studies, and the cure rate is about 40, 41% for a child like our patient. So again, those who are the germline, then they have that CD10 positive, so they do behave like the typical child who's over the age of 1 with ALL. So how do we treat somebody with acute lymphoblastic leukemia under the age of 1? It's never an easy journey because we have to deal with chemo resistance. As I alluded to, the first order of business is to get him into remission based on what we call an MRD or a minimal residual disease status. And so luckily, I did not have to intensify her treatment beyond what has already been intense because we did achieve that milestone after only 4 weeks of her induction. They usually suffer from high rates of relapses and typically while they're on therapy. So if your treatment is 2 years long, it is very important to see at what point do you relapse. Any relapse on therapy means you are really chemo resistant, and therefore you're not going to do well with any just standard chemotherapy. On the study that I have treated her on, the 0631, when the study opened up, it was a randomization because at the time there was a belief that these blasts have we call it a FLT3 mutation, and so there was an inhibitor. It's called listartnib, and so people were randomized. Half would get it, half would not get it, while you're still proceeding with the same chemo backbone. And when the data was analyzed, it really did not make any difference. Those who did not get it, the cure rate was 37%. Those who got it was 39%. So statistically, this treatment has been abandoned. And so really, we are now in an era where we're searching for something outside of the intensifying the chemotherapy. So then the question is, do you transplant these people or do you wait until they relapse? The jury is not out. Some people would take you straight to transplant, some don't. If you had AML in an infant, then I think that decision was already made that you put him in remission and then you take him to transplant. In the ALL, this has not been decided yet. There was that European study that I mentioned early on, the INTERFONT 6, where the intention was to put everyone in remission and then move on to transplant. But almost half did not make it because they relapsed before that transplant decision was made. And then in the remaining 50% who went on to transplant, 34% did relapse despite the effort to transplant him, and about 18% died from complications. So that still leaves you with almost 25%. So even in our best efforts with the intent to treat and get them into transplant, it's not really an answer that we have been able to answer. So there are some novel treatments. These are still in the pipelines. These have not been published. These are not officially available unless you are in a clinical research environment where you are doing some phase 1, phase 2 treatments. But a new wave is now to use what we call the hypomethylating agents. A classic one is now the cytarabine. People are using histone deacetylase inhibitor like vorinostat. There is a hospital, St. Jude's Hospital, that is trying to use this combination along with other things called bortezomib, which has been used in multiple myeloma. We are using venetoclax in AML population. So because these people have the myeloid antigen presentation, I think is going to move into treatment in conjunction with a standard chemo. Immunotherapy is now very approved in relapsed ALL. So we have a monoclonal antibody, the blinatumomab. which has now been used in if you have a refractory ALL. So, but it is only a bridge to get him to final transplantation. I'm sure you've heard about CAR T therapy right now. The issue is you're having these small infants, how you can access them, venous access, collection of enough T cells, manufacturing these T cells and re-infusing them. But I think this is going to be sort of a wave of the future because we cannot just rely on chemotherapy. I just mentioned that in the best case scenario, we have about 45% cure rate. The transplant did not prove to be really the way it was sold just because of the toxicity and these early relapses on therapy. So how the future is going to shape remains to be determined, but I think we are at the cusp of starting to introduce either targeted therapy or some sort of immunotherapy that hopefully we can mix with a proven backbone treatment so we can eventually achieve a cure for everyone. To answer an earlier question in the session prior, when we talked about maybe doing a stem cell transplant, the mother was pregnant and in fact almost 2 months away from delivering the baby. So we did counsel the family about doing cord blood stem cell collection. And we talked to the OB and everything was in the works, but finances got in the way. It is not a cheap thing to do. And so they declined doing it. But in cases like this, where you know the treatment is not going to be very successful, I think every effort should be made to try to find a donor in the immediate family. So that was a golden opportunity, but sadly the finances were the issue. So I think I'm going to close with this one and open the floor for questions.